All right, here we are again for our Down Fracture podcast, a podcast for talking jaws. Per usual, this is Dr. Michael Watson from Arizona Jaw Surgery, here with Dr. Sam Bobek. How's it going, Sam?
Good, Watson. It's good to hear from you. We have a special guest today, yeah?
Yeah, who is it?
Eric Holmgren. So he's joining us from the East Coast. I've known Eric for quite some time, actually. He was my chief when I was an intern at Oregon. So
Wow.
we've known each other, I don't know how many years ago that was, 20-ish, something like that.
2000s, yeah, 2006
That's
ish.
wild. So
I was in
I'd
high
see
school.
Eric's a surgeon at Dartmouth. He does he's a broad practice, but he focuses on orthognathic surgery, among other things. After a successful career in private practice. So he's over there doing reasonable volume, I understand, of orthognathics, and he joins us to discuss the nerve position in virtual surgical planning for mandibular osteotomies. That's what we're
Nice.
generally talking about, right, Eric?
Yeah, thanks for having me, guys. I think this is a nice topic and a good forum to discuss all things jaws and orthognathic surgery. So yeah, thanks for having me.
Um, so let's see. So I think Watson's got some pictures. Are we sharing those right now?
Yes, well, I mean, you can
Ah,
see it, right?
well, I can't. I didn't know it was being shown to everybody, but
Yeah, the world can
um,
see him, Sam.
oh, that's great. So yeah, so I think we have up. So there's this idea of virtual surgical planing in the nerve position, and I remember this from a long time ago. And Eric, you probably do as well. They just kind of came up with standardized pictures, and now they are like the go-to pictures that you get in your report. And one of those is the nerve position. And I think some of the things in the report can be just pictures, and we may or may not be really altering our practice with this information. Do you think this has been around for a long time, Eric? Because you've seen this as long as I have.
Yeah, ever since virtual surgical planning sort of really took over and how I plan my practices and treat the cases and 3D print guides. And I've always been curious where, they can map it out and do translucent bone windows. And I always thought that was interesting, but I kind of questioned myself, I mean, do I change how I do things based on that? And should I? Should I really stratify patients' risk based on this morphologic difference in the nerve path? And it's been a topic I've been thinking about lately.
So do you
Yeah.
find that you do change your plan, or do you feel like it's almost inconsequential?
Yeah, I think, obviously when I'm doing my lateral cut and, the instrumentation that I use, I'm thinking about where that is on the inferior border and how deep do I go and I, maybe change some of the chisels I use. But I don't know, I don't really talk about it with the patient and stratify their postoperative paresthesia risk, if any, based on their path. And one of the things I was thinking of, gosh, if you scroll up to that uh, path, that nerve path you have is pretty extreme. But if you scroll up to the one below it, when I look at that,
Like this
we've
one,
got,
or
oh yeah, the one up, one, I think one more below. Yeah, I look at that, I'm like, oh, great. I've got five,
yeah.
6 and 4. And I'm like, oh, I'm, pretty happy because I use a sonopet, so ultrasonic cutter. So I know the width of my blade. It's about 5, and I know I can sink it, and I'm pretty happy. And um,
You're gonna
so
trick Sam, man. I could just see Sam's about to just lose his mind over
I
there.
know.
No, no, that's not it at all. I think no, no, keep going. Keep going.
Yeah, sorry.
Yeah. I know. So that's what I do. And so I've been thinking a lot about that, those distances right there that you have. And should I put any mind to it? How does that change my plan, or should I stratify the patient's risk based on that?
Yeah.
Watson, what do you do? Do you alter your game plan based off of a nerve?
We when we were trying to set up this episode and we talked about the topic, you and I kind of spitballed on it a little bit. And I would say my experience has changed with experience. And, when I first started doing this on my own, I paid a lot of attention to it. And then I've kind of found that it's something when I'm planning, I feel like I almost just like automatically take some notes now, but I don't spend a lot of time like specifically looking at it. I mean, I look up, I look at how high up the lingula is to get an idea for my dissection. I do look at the inferior position as you guys were just talking about, okay, do I need to be really careful at the inferior border? But I don't find that it changes much for me other than I might go a little slower at the inferior border. And I feel like
Hmm.
that's about it. I still use a saw. I have a sauna pet where I am now, and I like it for certain things. I like it a lot for certain things, but I don't really do it here. I guess even when I did that kind of more extreme case, um, I didn't use it in that one. And I don't have well, I guess I do have it here, the picture. So I had plenty of room buccally, and then inferiorly is a little bit of the concern, but I still just kind of used the saw, and I mean, maybe went slightly slower. Um, Otherwise, I don't feel that I did much different. And am I answering? Is that kind of what you were asking, Sam, or were you
Yeah,
asking for
because I
something
mean,
different?
the information that's on these things, I mean, because I use these different these days. I'm a big fan of getting the movie, like planning. I get a movie because I plan in house. Um, because patient education about the nerve position, I think, is useful. But from our standpoint, in terms of changing what we do surgically, um, I guess I like this topic a lot in terms of minimizing nerve injury after mandibular osteotomy. Because I mean, that's the
Mhm.
premise of this, right? Like
Right.
we don't have nerve injuries, either a direct nerve injury or just compressive nerve injury after the fact. And so the position of the nerve, like the least risky position of the nerve for the inferior border cut or the Dalpont, like adjusting that position, I definitely designed that differently, based off of it. I don't, it seems to be somewhat helpful, but not like hugely helpful. Because how often you guys see nerve injuries?
Yeah,
Um,
yeah, go
I was
ahead.
gonna say that I've created or
Yeah,
that
like
I'm
in
seeing for
surgery that you see like a injury they need to fix.
not all that often.
Yeah.
Uh, if I'm thinking of
Relatively
like
rare.
this year, I'd say maybe I could think of maybe one.
Yeah.
And I feel like I don't feel like it was attributable to the osteotomy. Um, if that makes sense. Like I didn't cut it.
Yeah, it's pretty similar, Eric, in terms of your
Yeah, I
general
mean,
experience.
I can think of one this year where I intraoperatively repaired it. It's just
Mhm.
the afterwards, and the conversations we have with patients, before the surgery and spend a lot of time, and I don't know what you guys do, but spend a lot of time like, oh, I got to tell you about this nerve, you know. It's like a bookmark in a book, and sometimes we can't find it, and what does paresthesia mean, and what how long, and you start to get down this rabbit hole, and it'd be nice to sort of, I don't know, you want to talk about it, but how much do you want to talk about it on certain patients based on their patient specific anatomy?
Yeah. Well, I think you.
Like,
Sorry, go ahead.
and the other thing too, I start thinking about is like, so you have that one, static snapshot of where the nerve is. But like, what points along that path should you be looking at that would be more crucial than others? Like distance from the coronoid notch to the lingula, is that one?
Mhm.
Or right at the Delpont, or right at that transition from medial to sagittal. Like maybe those 3 points are all that you need. I don't know. Um,
Yeah, because I think I'm in total agreement with what you're saying now in terms of I think there's more than just the inferior position of the nerve or the proximity to the buccal cortex, right?
yeah.
Um, I think where the mental framing is variable. That limits where you can make your Delpont front to back, accessory canals, dual nerves, occlusal plane change, things like squishing the nerve after the fact, changing the
Mm,
position in relation to the proximal segment so that your positional screws are going to be in the way of the nerve. Like those
hmm.
sort of things is it's why I like the video so much better. I mean, can I just do video real quick? I just
Yeah.
have a
Do you have one ready?
just a case pulled up here.
Stop sharing. Yeah.
And
I mean,
and
I was gonna make that point too. If I almost feel like I pay attention to it more intra-op, like where is the nerve relative to where I might want to place my fixation screws or my plate. And like you said, like that case we were just talking about before we went on, where I got a pretty big mandibular setback. I want to take that Dalpont maybe more anteriorly, but where is the foramen? Where's the loop and all that where it may get in the
Hmm.
way? I feel like those are maybe more important areas where I look at the nerve compared
Yeah,
to,
because I mean,
like you're saying, at the inferior border and how much buccal space do you have?
this is a case that it's just an advancement case, so 2-7 MMA. But for nerve location, I mean, she's missing premolars, so metal framing, is a little bit proximal. You can see like where I chose my Delpont location just because I want to have some space to put a plate. But I mean, this is pretty proximal for Delpont. And then for movement, like she's having a big movement, right? She's having a lot of counterclockwise rotation. And so position of the nerve in relation to the rest of the mandible for positional screws will be different, right? I know
Hmm.
it's when I fly around with people in terms of showing them like compression of the nerve and management of things, like showing the video seems to be so much more helpful for education than just the pictures were. And it's
Yeah.
helpful for me as well to be like, oh, hey, most of my compression is going to be kind of like mid nerve. Like I'm going to have to remove bony interference if everything goes right, like right in this area. Maybe I get some better bone overlap, or maybe I design this differently. You know what I mean? Because I think it's not just the cut in front that's the issue. It's also the rest of the operation. Um, and
Show
so,
Yeah.
us your video here.
what's up?
Show us the video here.
Are
Or
you
are you?
not seeing the video?
No, it's not moving.
Oh,
At least
I'm
on
all
my
right.
seeing it.
screen. There it goes.
Okay.
Sorry, I've changed the teeth seems to be jumping,
Yeah, mine does that too from the CT scan overlap with the scan.
but she's getting a good amount of advancement. And I think this is more, like if you have nerve injury in the situation, this is a hard thing to sort out. But absent the rare nerve injury during the case, most of the nerve injury in her situation is going to be from compression of the segments, heart graft, plates, those sort of things causing that trouble. And designing it a little bit a different way can be helpful. Um, so I don't know. I think the picture of the VSP, I don't find it to be all that great anymore. I feel like it's inadequate. I feel like the video is helpful because there's a lot of different opportunities you can change to minimize numbness.
Hmm.
You think, I think there's some clear ones, like when the nerve is lateral. Have you guys seen that where the nerve's
Yeah.
outside,
Yeah.
like a revision case where the nerve's outside of the mandible?
Oh, no, haven't seen
I don't
that.
think I've seen it outside, but I've seen it very lateral. Yeah.
Yeah, so it's outside or functionally outside. I think the other one seems to be like if there's a big concavity on a coronal cut at the angle of the jaw, like the nerve just sits in a concavity. It just seems like it wants to snap the nerve kind of like mid split. You know what I'm talking about? Like
Yes.
you look from the front and it's just got a big C to it. That inferior border to the lingual part of the lingula just wants to just go through the nerve. Um, I don't know. I feel like there's some subsets of people that are at higher risk. It's just such a rare event. It's kind of really hard to quantify that. I think that's why
Yeah.
it's been kind of like poorly studied, Eric. Like you read in literature about nerve injury and it's such a broad range of issues. In real life, what could we do to minimize it? And I think design's possible, but it's got to be like in the overall picture of the design.
Yeah.
Does that make sense? I don't know. I
Yeah.
think for the the companies need to allow us to get the videos. I feel like just give us the data, and that way you can fly through and show
Yeah.
people. I feel like that's helpful.
Yeah.
Um,
I mean, I think, kind of going back to the point that you guys were mentioning at the beginning about quantifying it and how you discuss it with patients. I mean, I feel like I don't, and I want to clarify what you guys do. I don't feel like unless it was a real extreme situation where I'm not even sure I can think of an example or a recent one. I don't feel like my discussion with the patient regarding their risk of nerve injury changes. I kind of feel like it's all or not, like it's a zero sum thing. You're either numb and you get better, or you're numb and you don't. And predicting that is impossible because I mean, I've had patients, and I'm sure you guys have too, where you're like, oh man, that nerve was not encased in bone. It was hanging out the whole case. it's going to be traumatized, or I feel like I beat it up, or, a resident or someone gets aggressive with a suction a time or two, and they do fine. Like they're not numb for very long. Then I've had some where it's encased in bone, and I feel like I interacted with it minimally, and they stay numb for a really long time, or even, maybe partial minimal residual paresthesia, hypoesthesia indefinitely.
I mean,
Yeah.
there's definitely different camps. I mean, if you're to believe the paper from UW a number of years ago, probably
I don't
three or
believe
four
anything
years
that
ago.
comes out of that place.
Well, I mean, then you shouldn't even free up the nerve, just disregard it. I mean, if it has the same neurosensory outcome. Because they compared prospectively, I think it was a
Right.
split mouth trial, freeing up the nerve versus not freeing up the nerve, and the
Wow.
patient ended up in the same spot. I have a little bit of a problem with that paper in general, but there's definitely people in the camp of just leave the nerve alone, like don't alter anything you do. Eric, do you know these guys? I mean,
Yeah, I mean, I'm not familiar with that paper, but I've certainly felt like, hey, sometimes just leave well enough alone, just the act of isolating it and pushing it around and freeing it up. Like, what are you doing to it and causing a neuropraxia that way? Um, or, yeah, when the nerve is left in the proximal segment and you're just kind of doing a minor movement, and just screw it,
totally.
Um, I one thing I've been thinking about, and I don't know, I'm toying with the idea of doing this study because I have a student interested and I have ties to the engineering school, which can help me with a lot of stuff, is doing a prospective study looking at picking out some of these key points on the VSP, looking at patient-specific morphology, doing some neurosensory testing kind of before, and then the standard like day post-op, 1 week, 3 weeks, 6 weeks, 3 months out, and seeing if there's a correlate between that nerve path and level of a degree of neurosensory testing deficiency. Um, I don't know. And whether that's worth doing, if that would show anything, and plus it's just me doing it, the surgery and my technique and the types of movements, and I don't know.
Yeah, I mean, this is a hard area, I think, just because there's a lot of opportunities for nerve injury in the surgery. And so narrowing, like standardizing for those and just narrowing on, let's say, vertical position of the inferior alveolar nerve at the angle, and saying, well, there's low, mid, high, what's the highest risk?
Yeah,
Um, that's why I think the data is bad, is because it's hard to really like iron it out. It's like when Watson and I talk about TMD surgery, it's just like if it's applied generally, it's hard to know what we're getting out of this research. But if you could like whittle it down to where you standardize for like all the rest of things, it's just, I think it's going to be hard. Um,
yeah,
I think, when it comes to these, there's like high risk and then probably most average, and then there's low risk people. I bet you could figure out the high risk people, right? Don't you think?
yeah, yeah,
Like just find out the people who end up numb and figure out what the like what were the highest risk of those.
yeah, yeah, exactly. And what data points are important in those cases, and what kind of movements are being made?
Have you
Or you
changed
mean,
much in the way you manage the nerve these days, Eric, than let's say 10 years ago?
Um, I mean, I do, I guess just intraoperatively, just some of the things I do with, I don't know, I do ultrasonic cutting. Um, yeah, I think since adaptation of the instruments I've been using, but the last 5 years, I just pretty much do the same thing over and over and over and over again.
Yeah.
Um, so I think I would say yes, just in terms of instrumentation, but not necessarily treatment plans or risk stratification.
Yeah, I wonder if you could get the engineering department to let you start doing some of the planning in house. Like if you can get your residents or some other people doing that.
Yeah,
Because you start playing with the Del Pont, like for different reasons, for overlap or for face change or design. I know Watson's not a big fan in customizing the sagittal osteotomy, but I think I'm joking. And he likes it. It's just
you're
I
not the
think
only one with
that's
feelings.
there's things that are just overlooked because of the nature of how the workflow goes, just because the
Mm,
planning company just designs it generically, then we practice in the generic way.
yeah, true.
But if you had the opportunity to screw with it, like let's do a like a cut at the angle versus one up by the foramen, um, or cut beneath the nerve on the ramus or above. Like I feel like there's clinical situations that support a lot of the different practice ways.
True.
And I got to believe that Dartmouth's got some engineers that want to do that, like some students that
Yeah.
want to do that.
Yeah, for sure.
It's just got to be tough to bring it through admin, right?
No, not necessarily.
Oh,
There's
okay.
a lot of things that can be done. And I don't, especially the engineering school, a lot of eager people, a lot of, things can, can get things done there. It's nice. Um, so yeah.
What do you think, Watson? You do anything different on your upcoming case for nerve? That one we were looking at in terms of setback?
That case, the nerves, like I don't even know where on my concern and priority list that falls with all that's going on with that one. But you asked the question earlier, do you manage the nerve differently? And I recall, you correct me if I'm wrong, you're a free up the nerve from the proximal segment every time kind of person, are you not?
Yeah.
So no
Yeah. I
matter
mean, I
what,
think
small
I've done
small
that.
movement, it's in the proximal segment, freed up. You do that every time.
Yeah. I mean, if I don't find the nerve in the distal segment, I won't like uncover it. But if it's in the proximal segment, I'll free it up every time.
What's your rationale for like in a small movement? Like, why do you feel like that's advantageous?
Um, because I think that the movement has complexity to it. I think there's generally a 3D movement. So there's yaw to the distal segment, or there's some occlusal plane change. Like it's pretty unusual to be just a linear movement when it comes to what's happening at the nerve. And the nerve can totally be pinched. I mean, I think that most paresthesia comes from that, like pinching of the nerve or compression of the nerve. And so freeing it up, I mean, honestly, freeing up is not a big deal these days. I used to hate that part of mandibular osteotomies. Like if the nerve's in the proximal segment, it's like you have a big sigh, and I'm like, I know what I'm gonna be doing the next 30, 45 minutes is freeing up this nerve. Nowadays it isn't a big deal. I mean, the rasp helps me out a lot. And so it doesn't seem like I spend much time operating to free that thing up anymore. And the nerve doesn't look like it's beat up. Like when you free it up and it looks like it was just
Yeah,
attacked, and you
yeah,
think, gosh, did I really help this situation? Uh,
Yeah.
yeah. I think that's the rationale for I do similar to what he was saying earlier in the sense that small movement, if it's in the proximal segment or whatnot, I kind of worry about doing more harm than good. And we go back to the quantification, trying to quantify what would be more damaging to the nerve, which is
and so it seems at least like using the rasp not over the nerve, but adjacent to the nerve, like above it to like get the medial aspect of the canal to just flake off, for lack of a better
Hmm.
word,
Hmm.
seems to be it's easier to be aggressive. And so that way it just basically splits to where it allows you access to the nerve. I think that's probably technique refinement. It just looks like it's the right thing to do because um otherwise you're adjusting the bony interference over the nerve, right?
yeah, to avoid compression or interference, is that what you mean?
Yeah.
Yeah. Yeah, in
I
theory.
mean, and again, I don't have literature with it because I find this to be a hard topic. But there was, I don't know what it was, 4 or 5 years ago. I don't know, Washington, you probably know better than I do. But when did I don't know, I felt like we took it on ourselves to try to decrease the risk of numbness. Like it really switched over to plates. Um, Started treating the nerve quite a bit better during the operation. Not that I was treating it poorly, just kind of focusing a little bit more on it. And it's not unusual to have normal sensation after surgery. I know it sounds crazy, but that's not an uncommon thing.
You're
Uh,
saying it's not uncommon in your practice to have patients that don't have hypoesthesia following mandibular osteotomies?
yeah, like the day after surgery. I mean, that's not an unattainable outcome. And that seemed like an impossible inner
Yeah.
thing to carry out. And I know that's not all that meaningful, but I think it's kind of meaningful. It's kind of like blood loss, right? Like, I mean, recovery is way easier if people have some sensation in their lip. They can just drink out of a cup.
Yeah.
And so obviously I'm trying not to have any numbness. I don't think it's 100% successful. But this is like a hard thing to compare, right? Like,
It'd be interesting to look at those patients. Like what kind of movements have those patients undergone?
There's some
Um,
crazy movements for sure.
and what was their, I don't know, and just what was their nerve path, and like
Yeah,
maybe there's no correlation. It's like, ugh, just dumb luck, like could it
totally.
be just dumb luck, or is there something in common with those patients?
Because I'm open
You
to the
know,
idea. I'm biased in the positive way, right? Like I change things and I'm lying to myself that I'm having better outcomes than I am. But I do
yeah,
Andrea kind of keeping an eye out for those sort of things as well, which I like that. Did you meet Andrew when you were here, Eric?
yeah,
Maybe not. She's my PA.
yeah, yeah, yeah.
Um, yeah, so I like her examining independent of what I think when it comes to the numbness, just to have another set of eyes on it.
What are you doing for your how inquisitive are you with your patients postoperatively regarding the numbness? And what kind of
Probably too
testing are you doing?
inquisitive. I'm
Too
bad about
inquisitive.
this. Yeah, I feel like, and I know Watson's brought this up to me, which is it's good advice. Drawing attention to those sort of things probably draws the patient's attention more, right?
Yeah, yeah. Initially I tend not to go. Yeah, for I worry that they're going to perseverate on a little bit and feel that something's wrong.
Yeah, totally. So our 6 week is when we start testing, at least with just like the Q-tip neurosensory test is doing a good thing. And then 6 months is their other data point. But we generally ask them, how are you doing with numbness? And then, sensation. People say, I feel great, or everything's totally numb. You know what I mean? Like
Yeah.
the
So what do
subjective
you with
exam.
this newfound attention to the nerve and having decreased hypoesthesia in your patients, how does that change how you counsel them preoperatively? Because I pretty much just tell everyone you're going to be numb. The question is how long, and then if they're not, they love it, right? And so it's
Sure. Yeah, no, I think it's the same. I just don't think the risk of having total numbness, because what people are worried about is total absence of sensation and pain. Like
mhm.
they don't want pain and they don't want to be totally numb. Like paresthesia, I feel like most people can manage. Not that you want to have that as an outcome either, but this assumption that everyone should have some paresthesia after mandibular osteotomy, I don't think is true. Um, and
Long term. I agree with you. I feel like short term, that's a challenge. I mean, I think just even things that you try to protect the nerve intraoperatively, but it's sometimes such a simple thing of whoever's assisting gets it in the suction.
no, I
Or
mean,
I mean,
you
it's just
working
something
on the
like that, and
left.
you go, "There's 2 weeks," like
I
who
mean,
knows?
working on the left split, I always think about like what's going on the nerve on the right side, right? Like
Hmm.
you're
Hmm.
twerking thing, tweaking things. I think I said twerk there. That's not the right word.
You do
Um,
twerk a lot
Yeah.
but I could imagine compressing the nerve or causing injury indirectly in that situation, right?
when
Uh,
you when you're
working on the
making
other
a
split.
split, and yeah.
Yeah, I don't know. It's funny how I don't know where this just carry over from someone in residency, but we used to not do the just make the cuts and then go back to the right side, then do the osteotomies to finalize it and then go, you know what I mean? Like,
Yeah,
um,
who did that, by the way? Was that
was that,
a
I think that
Salem?
was, no, that was,
That's
Kelly,
definitely
I
in
believe.
who?
Oh, okay. Dr.
Usually
Kelly.
Kelly, maybe.
I believe that.
I
It's
mean,
definitely
yeah,
that's how it's presented in the Posnick book. Of
yeah,
do you want osteotomy, do your cuts on one side, do them on the other, finish your split kind of thing, which just seems, I don't know. Do you guys switch sides of the table when you're making your cuts? Like, because that just seems like a lot of back and forth,
yeah,
driving me crazy.
Yeah, I mean, I just do right side, split it, go to left side, split it, put them in intermediate splint,
Yep.
fixate left side, fixate right
Fixate
side.
right side. Yep.
yeah,
Yeah.
yeah,
If I had to go
Uh,
back and forth, I mean, I guess if you have two, three surgeons and each person's doing their side, maybe not a big deal. I mean, it's not the end of the world to walk to the other side of the table, but it's kind of annoying.
sure. Yeah, I mean, I think the other part of nerve stuff generally has to do with bone healing. I feel like, you can be too focused on nerve and forget about the bony union. Um, because generally the nerve freeing up stuff that I do takes away bone. And I've definitely entertained that I'm causing more bone trouble. What do you think about that?
yeah.
Like freeing up the nerve, you take away the bone contact that you would have had that would have helped you out with bone healing. I feel like those two philosophies argue against each other.
Well, I'm fond of telling you that you need to calm down on these things. And I think this is an example potentially of that. But I mean, if you're not getting a
Maybe,
lot of malunions, non-unions, and you're having
yeah,
improved neurosensory, responses in your patients, which it sounds like you are, then I think it's a tough thing to argue against.
Yeah,
Yeah, I
maybe
mean that.
switch to the.
Yeah,
Yeah,
go
go ahead.
ahead. No, no.
I was going to say, and jokingly, maybe switch to the hand rasp versus the mechanical rasp.
Yeah. Yeah, I don't know. I mean, because that's another one that's such a rare event. Mandibular non-unions are a bit unusual, but I think it has to do with the single screw, right, Watson?
Yeah, man, you got to stop doing that single.
Oh, the single screw's the best. It's
Oh, the positional screw
yeah,
on
he
that.
wants me to put two positional screws
It's a
in.
single positional screw in a plate, which is
We have this
adequate fixation. It's just like
like ongoing bickering.
poked a
Single
hole in their
screw.
face. You've got a trocar.
Might as well do two.
Put at least two screws in there.
Hey,
Um,
yeah, yeah, I could go on forever about that. But
and and then what do you think about does the nerve position, does it ever get so bad that you bail and you do an L or you do a TJR?
oh,
What
It
do you
would
think?
take a lot for me to do an L.
mm.
All right. Eric, you're in the same camp?
Yeah, I mean, I rarely like to deviate from what works for me. So yeah, yeah,
Yeah, because I mean there's stuff that's out there that you hear about and people talk about it. L's a hard operation.
yeah,
And I mean it's a good philosophy. It's just also I think it can result in numbness as well. You know,
Yeah.
like the
hmm
the screws at the inferior border, if the nerve is at the inferior border, I mean, I find that L still has a risk of nerve injury in those weird cases. So
yeah.
Yep.
I don't know if we solved anything. Are you guys gonna adjust things differently or no? Probably just talked about it, make us feel a little bit better about it.
Yeah. I think I will. I mean, I think sometimes there's value in hearing what other people do, obviously, but I think when you start thinking about possibilities and outcomes, hearing that certain things have been achieved, I think changes your mindset a little bit. I mean, the hearing you talk about how you've improved your patients' levels of since hyposthesia, paresthesia, it kind of makes me feel like I could do a better job. Like, I think we all make a concerted effort to protect the nerve. But if you're saying you have patients like even the next day who don't have sensory deficits, like I don't know that I've achieved that all that often. And so
Sure.
it makes me want to say, well, maybe I'm not doing enough. Like you feel like you're doing the right thing, you're doing what you're trained, you feel like you're doing enough. Then you hear someone having better outcomes, and it makes you wonder if you are, in
Well,
fact,
because
doing
I
enough.
mean, part of that it's like I don't want to I don't want to say it's true, right? But then it does take a lot of reps because we do a lot of this, and I feel like it allows us to kind of tweak little things to see if it's really making an impact. Um,
Yeah, it's hard to, my current situation, oftentimes I feel like I'm doing too many things at once. I feel like I'm involved in how getting the room and the instruments set up, and
sure.
I don't have consistent same help assisting. And so it's like you only have so much bandwidth at each moment in time. And so it's kind of like I'd
There's not
love to
wrong.
have a consistent situation such as yours to where I can focus on some of those ancillary
Yeah,
things that maybe are big, big changes. That's a big deal. I mean, not having patients that don't have any paresthesia consistently, I think is pretty remarkable. And I think
yeah,
Uh,
and
it work
I
towards that.
think too, focusing on, I think this discussion just makes me want to focus a little more on asking the patients and not being nervous about asking them about what their numbness like, maybe documenting it a little more in the early phase. And then so getting a real snapshot of what are my outcomes early on. Because sometimes I haven't been focusing on that. And then what did I do differently with these patients, or what kind of movements do these patients undergo? And focus more on those good positive outcomes, and see if I can find a correlation. I don't know, just maybe focusing on a little more post-operatively would be of
I mean,
value.
I think what you guys are talking about sounds totally right, with the exception when Watson said frequently people have full sensation. I want to clarify. I mean, it happens that people have full sensation, but it isn't like half my patients have total sensation, right? Like it's
Yeah,
improved. It's not like it's down to zero. But the general premise, which is I think we can alter some of the ways we do things to improve patient outcomes, just because a lot of
definitely.
data that exists in this world is hard to figure out. And with the tools that we have and network of people to talk with stuff, I feel like a little bit of tweaks here and there can play out pretty positively.
Yeah.
Yeah.
I mean, I think you should start using the piezo for sure, if that's
I
what you're getting
used
at.
that before. I used piezo. I had a case where I was revision. It was, I don't know what it was, like her second or third case, and the nerve was outside the mandible, and so I was using piezo, and it was uh self-watering, which was nice. It squirts water while you use it.
The
What do
Sonopet, you got to try the Sonopet.
are you using the Sonopet fully, or what do you do?
No, I use it for my interdental osteotomies a lot of the time.
Yeah.
Um, Other than that, I use it for TMJR actually a fair amount when I cut off condyles. I like that sensation of being a little protected. It does slow things down. The saw would definitely speed things up a little bit. But again, also sometimes working with the residents, it's nice to have them even kind of mark it out or me mark it out and show them like stop. Because Sam turned me on to something a while back that I utilize, and that's cutting off more than you think of the condyle, the ramus condyle. So even if you're not placing your top screw, maybe this is a topic for another day. You want to make one cut, and so I think having residents mark it out or me marking it out and showing them, hey, look, you're looking at the plan, but here's what I do. Here's why. Do you see where my cut is? I think that's sometimes harder to do with a saw. Um, and I just like the control. But I think using it in the maxilla to make your horizontal cut, I think that would drive me crazy. Um, Even a lot of the mandible. Maybe this, I don't know. Are you using exclusively the Sonopet,
Yeah.
even in the maxilla?
Yeah. Just because it's a pain to switch back and forth, and
Yeah,
I don't have consistent help. So like I
Yeah.
try to like just do one thing.
yeah,
Um,
Do you
that
use
does help.
a suction that rinses at the same time? Do you use like a Vital View or an SR or anything?
no, it's just the Sonopet has water on it,
Yeah, because I
and
mean,
yeah,
if you don't have hands, like having a instrument that irrigates itself is
Absolutely.
great. Like, I
yeah,
mean, that
yeah,
frees up a hand. I mean, I got a suction thing that squirts water, and so I mean, piggybacking the water, I could see that as the best advantage of the Sonopet business.
yeah.
Um, yeah, I've been a slow adopter to that technology. But yeah, no, it's
I needed, I don't know. I just feel like I'm not as skilled with the saw and get the cuts I like. I like to like
no, it's
whittle and draw it, and then it's like I feel like I don't know. It just
well, it's
feels like I
cool
have more control, and
because
but it's slower.
they have a bunch of different things on it, right? They have those little corners and everything else, and um,
Yeah,
yeah, that's seems neat. So yeah, it's definitely got a good place in this. So
I think the Sonopet's a game changer though, because typical traditional piezo is maddeningly slow. And the Sonopet is slower, but it's not comparable to just general piezo. And I think that does make it expand its uses. Because if you had to make all your cuts with a traditional piezo, oh my gosh, I mean, you'd
yeah,
be there all day.
yeah, yeah, but I'm sure that's there's good data to support that reduces the risk of nerve trouble. I think that's Italian data. I think so. Nothing wrong with that.
Yeah.
So,
there was,
sweet.
but yeah, just quick note on that. I do worry about hearing loss with the vibration. There's something about that. Had one
Huh.
patient with some issues, just the ossicles. There's something going on. I have to look into that, but it hasn't really happened to me too much. But I had one patient that had some hearing issues.
Hmm.
Yeah, I mean, it seems like there would be some side effects to it.
Yeah.
And they make ones that don't have a huge body to them, I assume, right? Like
Hmm.
like a large diameter. There's thinner diameter handpiece part of it.
Yeah, exactly. It's pretty nimble.
Yeah, the ones I have it at the hospital is this big old thing, and I think plastic surgeons use it. Anyway,
Yeah, I think most places that have a good neuro presence tend to have them, the Sonopet.
yeah, there's a rep that harasses me all the time about using it. It's just I'm cost conscious and speed conscious and outcome conscious. So it's hard to
Yeah.
convince me to change too much.
Yeah.
Um, but yeah, I mean, that's great. I might check it out. Well,
You're not gonna. We both know you're not gonna check it out. Like,
I'm
why
Yeah.
unlikely to.
say
But I
that?
mean,
Yeah. Yeah.
if I'm at a meeting, I'm coming up to the winter meeting. I think seeing that booth, if it's there, checking it out and being like, hey, because I'm trying to pick up some new things, and so
Do a split mouse study. Sam with the saw, Sam with the sonopet.
don't you think that would be slow though? Or
I'm
yeah,
gonna try
you
it.
could.
I can get through. I don't know. I kind of lean on that thing a little bit, and I don't know.
Does
But
I do wish they would replicate. I wish they could do a better job of replicating like saw blades, but in piezo, like because making your horizontal cut with that thing, that does seem like it would be a little challenging getting it back there. And then, the blade is only so small, so you have to, like draw it out. Um,
the
compared to,
one I use looks pretty much like a small recip saw.
really?
Um, yeah.
You have a tip on your Sonopet that's kind of like a
Y-
small recip saw?
Yeah, it looks just like a recip. And it
Oh man,
goes
I'm
it
getting the
cut it
shaft.
cuts it cuts 180. Um, so
nice, and you have good feel with it. You feel like it's the same feel as the saw.
yeah, good tactile feedback. Yeah. Um,
It's
and
not the same as a saw, but you feel it go through the cortex. Like you feel,
yeah, and I
yeah.
use it like a saw too. I'm kind of like going back and forth. I draw it out initially, and then I create my like my bobsled, whatever, you know, on it, and then just lean into that, and then get through. The buttresses are pretty easy to get through, and I cut back to the pterygoids, and I don't know. I don't know. Maybe it's just
Yeah,
because all I use, and I kind of committed to it.
yeah,
But
that's great.
Hmm. All right.
Well,
Well, thanks for coming on. It was a great topic. Hopefully it
yeah,
was valuable to anyone who listens to this.
Eric, it's good seeing you, man. Merry Christmas. I appreciate it. It's a busy time of
Happy
year, so
holidays to everybody.
yeah, for sure. Anytime, guys. It was great to talk some jaws.
Yeah,
yeah.
if you have some more topics, hit us up.
Yeah, for sure. I'll keep some in mind.
Sweet, man. All
All
right.
right. Well, that was another Down Fracture podcast for Talking Jaws. Uh, remember, if you would like to email us any topics, downfracturepodcast@gmail.com. Make sure you protect any pertinent, identifiable patient information, but topics, cases, anything you want to email our way, downfracturepodcast@gmail.com, and we'll look into it. All right. Thanks, guys. See ya.
All right. See you later.
See ya.
Bye.